So in this final video on hepatobiliary pathology, we're going to look at some of the inborn errors of metabolism, hemochromatosis and Wilson's disease, as well as liver tumors, and then we'll explore gallbladder disease. So the liver is very susceptible to iron overload disorders. Now, iron can't just float around in the blood or the tissues. It has to be bound to proteins. So there's several different iron-carrying proteins. So one is actually called transferrin. Transferrin transports iron from the GI tract to the bone marrow. When red cells undergo their destruction in the spleen and the hemoglobin is liberated, the iron is taken out, attached to transferrin, that goes to the liver, to the bone marrow to be reused, recycled into new hemoglobin. But there are a couple of other storage proteins. So one of them that's very rich in the liver is called hemosiderin. This is an iron-rich protein that specifically stores iron in the liver. So hemosiderosis is an excess iron storage in the liver with a normal liver architecture. So that's just, you see more hemosiderin in the liver, but the liver there's no inflammation, no damage to the liver. And this usually results from just taking too much iron. You ingested too much iron, the liver accumulates that, the hemosiderin kind of stores it for you, and that will, if you stop taking it over time, will dissipate. Sometimes it happens in alcoholic liver disease, partly because alcohol can enhance the gut absorption of iron, so you get more from the diet. Hemochromatosis is another condition when you get excess iron without subsequent with consequent cirrhosis, unfortunately. So hemosiderosis is more benign. Hemochromatosis is now when we get potential for cirrhosis. And there are two different forms of that. I'll start with the second one here. That's secondary hemochromatosis. And that's usually due to excess iron intake or anything that's going to increase iron absorption or lack of elimination. So that's typically going to be done by people who are overtaking iron, maybe for anemia, something like that. It's the primary or genetic hemochromatosis that can be a real concern here. And this can result in the body just holding on to too much iron and not excreting it properly. So we get iron overload. And so we get excess iron absorption from the gut. In the blood, iron levels can actually reach 40 to 60 grams. Normally we have about 4 grams of iron in the blood. And iron is very oxidative, so it's going to create more free radical damage and so forth. This is going to be more common in men. And that ultimately results in hepatitis and going to progress into cirrhosis, as well as destroy the pancreatic islets, where it might result in diabetes, and it accumulates in the heart muscle, resulting in heart failure. So the main treatment for this is periodic phlebotomy, is to just get the iron out of the body to detox it that way. So that's hemosiderosis and hemochromatosis. Now we're going to see later there's another iron storage protein, and that is ferritin. In fact, we measure ferritin as a measure of people's iron stores, and that's going to be iron stored in your other tissues like muscle and other tissues. But it's the hemosiderin which is stored in the liver, and then hemochromatosis is a condition where we're going to get actual liver cirrhosis and or liver damage from all that extra iron. Another metal storage disease would be Wilson disease, and this is an inherited disorder of copper metabolism. Iron and copper are kind of opposites. We can think of iron as we might call this an incarnation metal. It makes us very grounded in the body. In fact, people with hemochromatosis I've seen almost look like they have hyperthyroidism, very anxious, a lot of energy, difficult sleep, that sort of thing. Versus copper is more calming. Think of iron as more sympathetic and copper is more parasympathetic. Kind of like magnesium in that way. So the copper kind of relaxes. We often use copper in small amounts as a muscle relaxant, like homeopathically, things like that. But when copper accumulates in the liver, it can destroy the liver, cause the progression towards cirrhosis. It can also accumulate in the basal ganglia of the brain, and that can cause movement disorders and whatnot. So in this case, the liver can't excrete the excess copper in the bile, and we start to get all the classic signs that lead up to cirrhosis. The copper will accumulate and it will create, for example, some signs we can see early. One is called the Kaiser-Fleischer ring, and that is this kind of yellow-green ring that actually forms from copper accumulation around the iris. There is a copper-carrying protein in the blood. It's called ceruloplasmin, and that actually will decrease. So decreased ceruloplasmin, that's kind of the body trying to say, hey, there's too much copper here, is a sign potentially of copper overload. And then on liver biopsy, we might see copper there. So there's a lot of symptoms both in the liver, so that can lead to all of our liver problems we talked about. On the kidney, can damage the kidneys, the heart as well, again, just like the iron did. It can result in hemolysis, your red blood cells split, but probably the biggest one we see is central nervous system. And there's a lot of psychiatric and just cognitive issues that can happen. So deterioration in school performance, behavior changes, handwriting begins to deteriorate, resting and intention tremors, any dysarthria, difficulty speaking, excess salivation, almost like a Parkinson's-like picture, and that's the accumulation in the basal ganglia. So these would all be potential indications that a person needs to be tested for Wilson disease. So keep that on your list. Is not common, but one of those things we might need to see. The treatment is actually with a copper chelator. That's called penicillamine, and that can actually remove excess copper from the body. Finally, in terms of the liver, let me just say a bit about liver tumors. They really fall into two groupings, the benign tumors and the malignant tumors. The benign tumors would include things like hepatic hemangiomas, the most common type of liver tumor. It's found in up to 7% of adults. It's mostly diagnosed in middle-aged females. Female to male ratio is about 5 to 6 to 1. It begins in blood vessels in the liver. They're small and asymptomatic. Generally, no treatment is needed, and they're often found just on incident imaging. So here's a hemangioma. And basically, the big problem comes in with the larger ones. They might start to bleed, and that might need a surgical correction. Some express estrogen receptors, so we think this could be driven by estrogen. And so I kind of treat these, if I'm going to support them, by monitoring, but also by improving the liver's ability to detox estrogen. And that often is by supporting methylation or sulfation or one of those pathways. Another benign liver tumor is the focal nodular hyperplasia. And so you get these really weird looking lesions on the liver with a kind of a core. This is a result of a congenital arterial venous malformation. They're usually asymptomatic. They're not malignant, but again, they can bleed in some cases, and they might need surgical correction. And then finally, there are benign epithelial liver tumors called hepatic adenomas. They're usually associated with oral contraceptive use, again, maybe driven by estrogens, usually solitary tumors in the right hepatic lobe, up to 30 centimeters in size, so they can be pretty substantial. About a quarter to half of them can cause right upper quadrant or epigastric pain. They do have a high bleeding potential. They'll bleed into the peritoneal space, and they usually resolve after discontinuing contraceptives. And there's a slight malignant potential on these adenomas. But whenever I, have if a person is suffering from chronic right upper quadrant pain, been going on for several weeks, they're not improving with anything, we often will just, again, get the liver function test. We might get an ultrasound just to see that there's nothing there. And these will all generally show up on ultrasound. We can then order a CT scan to see if further assessment is needed. And then finally, we've already talked about primary liver cancers. That would be the hepatocellular carcinoma. Most frequent malignant primary liver cancer. But overall, it's much rarer than the other cancers, especially secondary cancers in the liver, so metastases from other organs. Again, most tumors in the liver in the U.S. are from mets from other organs. The liver is involved in nearly 1/3 of all metastatic cancers at the end, and most patients die within a year of liver metastases. So that's usually an indication of a very poor prognosis if it's a secondary liver tumor. But primary HCC also has a very poor prognosis. It's typically caused by chronic Hep B infection, Hep C, it's 25% of cases globally, alcoholic cirrhosis, then we have the hemochromatosis, alpha-1 antitrypsin, aflatoxin from Aspergillus, that's a fungal contaminant in food, we think is a big player in different populations for driving liver cancer. And then type 2 diabetes with the NAFLD-NASH, we're seeing an increased risk, and that continues to increase. And that's going to be up to 7 times the risk of non-diabetic patients. Tends to grow into the portal veins, and it can actually extend into the vena cava. It easily metastasizes, usually to the lungs, the portal lymph nodes, and the pleura. So we can see, pleural effusion, that sort of thing might develop from that. Can be more nodular, so that'd be more isolated, like you see in this picture over here, or infiltrative. It looks like it sort of spreads everywhere. Very poor prognosis on this one as well. Only about 10 to 20% can be removed surgically, and the survival is around 6 months statistically. And patients usually die from cachexia. That's starvation, basically, from the tumor. The tumor mets actually use up all your nutrition, and you develop malnutrition from that. The tumors also can rupture and bleed, and then even progress into cirrhosis. So that's a little bit there about hepatocellular carcinoma. I didn't list any of the treatments because, again, and many times by the time it's diagnosed, the support is often palliative. But there may be some different options available in terms of surgical removal of different tumors, as well as chemoradiation and some of the newer immunotherapies. Of course, we have the potential, of course, of the herbal medicines and acupuncture. I don't know of any statistics anyone has looked at that, but those would all be potential, especially for end-stage hepatocellular carcinoma, things for people to try. Finally, we come to gallbladder disorders, and I'll just list off the most common ones here so we know a little bit about them. But probably congenitally the most common is biliary atresia. Your bile duct system just does not form. And again, we're talking about the whole bile ducts, so the right and the left hepatic duct, the common hepatic duct, which joins up into the common bile duct, which joins up with the pancreatic duct and drains into the duodenum. And then we have our cystic duct in the gallbladder that hangs off of that. So the most common gallbladder disorders would be cholelithiasis, and that's having gallstones. Now, just having stones is not necessarily a problem. A lot of people have stones or gravel, and they're asymptomatic. We can get stones that go, and that's stones in the gallbladder itself. We can get stones in the bile duct, and that's called choledocholithiasis. That's anywhere in the biliary tree. And then if we have inflammation of the gallbladder because of the stones, and usually we have inflammation with infection because the bile is blocked from leaving, the pressure builds up in here, we get fermentation, and we can get lowered immune responses. We get bacteria that infiltrate, that are usually just commensal bacteria, gut bacteria, but they can now grow, and that causes cholecystitis. And so that's inflammation/infection of the gallbladder. And that can lead to a gallbladder abscess. That can lead to ascending cholangitis, where the infection spreads upward towards the liver. And that can also result in rupture of the biliary system or the gallbladder, peritonitis, and we'll go into all those complications. Other bile tract issues, so when we say gallbladder, again, I'm referring to the whole bile duct system, is what's called biliary dyskinesia. And that's where the gallbladder in particular has lower than normal function, and that's often due to ongoing cholecystitis or some gallbladder inflammation. I should say cholecystitis can be acute. That's the one we're most familiar with. You get the severe pain, fever, nausea, vomiting. You often need the gallbladder removed at that point. Or chronic, which is much more insidious. It just kind of lingers, kind of episodes of acute, they resolve, and so forth. And over time, that can create scar tissue that can result in biliary dyskinesia. Primary sclerosing cholangitis, PSC, is ongoing inflammation damage to the biliary tree, and that leads to scarring of the bile ducts. And that's often associated with ulcerative colitis, which is, again, a type of inflammatory bowel disease. And this increases the risk of hepatocellular carcinoma. And then there's primary biliary cholangitis. So we have primary sclerotic cholangitis and primary biliary cholangitis. And that is a rare autoimmune disease that destroys the bile ducts. And that leads to cholestasis and liver cirrhosis. Again, sorry about the typo here. This is primary sclerosing. Sclerosing, I think my autocorrect did that. Primary sclerosing cholangitis and primary biliary cholangitis. Okay, and then gallbladder cancer. We can get a cancer of the gallbladder. That's usually an adenocarcinoma. Remember, an carcinoma is a tumor of epithelial tissue. Adenocarcinoma is a cancer of a glandular epithelium. This is relatively rare, but that might occur because of chronic inflammation in the biliary system. And then gallbladder polyps, these are benign. These are just little growths on the inside of the gallbladder. They usually don't need any sort of correction, but they can actually, if they get too large, they can block the cystic duct, and that can be removed by cholecystectomy, which is removal of the gallbladder. And that procedure for most uncomplicated gallbladder issues is going to be done via laparoscopic procedure. So laparoscopy, you just make a couple of incisions in the abdominal wall. They remove the gallbladder. They basically just cut the cystic duct, but the whole bile system stays intact. So you still make bile, you still secrete bile, and in fact the common bile duct over time begins to swell a little bit and becomes kind of like a secondary gallbladder. So it can really take over the function. So just because you've had your gallbladder removed doesn't mean you don't have the ability to make bile. You're going to have less bile and less ability to, of course, emulsify fats. You might need to take extra bile salts with meals, that sort of thing, or eat smaller fatty meals with less amount of fat in them. But over time, like I said, the common bile duct might actually compensate. So again, in Chinese medicine and those traditions, when we talk about the gallbladder, we're not talking literally about the anatomical gallbladder, we're talking about the whole biliary tract. Now, classically, patients will say, well, I had my gallbladder removed, and so I have no gallbladder problems. The reason the gallbladder was removed was most likely from cholecystitis and cholelithiasis, gallstones. And the factors that led into gallstone production really are not localized to the gallbladder. They start up in the liver, so not producing enough phospholipids and so forth. So most likely those patients still have significant cholestasis even with the gallbladder removed, and they can benefit from therapies to increase the bile flow and so forth. So in terms of assessment of gallbladder disorders, our history and physical exam, now a classic sign of on physical exam of an inflamed gallbladder would be something called Murphy's sign. And that's where you have the patient lie on the table and you're actually feeling, so this is kind of orient, the person's head is up here, this is the bottom of the rib cage right here, and this is the liver, the gallbladder is right there. So you're asking the patient to exhale, then you place your hands, palpate, press down below the costal margin on the right side, the midclavicular line, and then you ask the patient to take a breath in, and as they breathe in, their diaphragm comes down to meet your hands, but then if the gallbladder is inflamed, it's going to press on that, and that is going to, so the diaphragm actually is above the liver. So as you inhale, remember the diaphragm is going to contract, it's going to push the liver down towards your hand, and if the gallbladder is inflamed, it's going to push it towards your hand, and that's going to create, a patient will stop breathing, they'll wince, and that's pretty indicative of gallbladder inflammation. Sometimes liver function tests like bilirubin and whatnot can be helpful. CBC might indicate infection, but our best test really is imaging. So we use ultrasound to test for gallstones typically. A more detailed examination would be scintigraphy, and that is called the HIDA scan, and that is using a radioactive tracer to really visualize the whole biliary tree to see if there's any blockages or obstruction or fibrosis. ERCP is the endoscopy where it goes down into the duodenum, up into the bile duct system, and then CT MRI. So these would be all potential assessment tools for gallbladder disorders. So just having gallstones is called cholelithiasis, and there's several different types of stones that can form. I'll talk about that here in a minute. If the stones are in the bile duct, then we have choledocholithiasis. So you might hear both those terms. There's over 1 million new cases diagnosed in the U.S. a year. About 20% of Americans, we think, actually have gallstones to some degree. The majority are asymptomatic. about 50% will at some point need surgery. So this is a very, very common surgery. And the mortality rate at this point with the new surgical techniques, laparoscopy usually, is less than 1%. So here is a gallbladder opened up with all the stones. Sometimes when they're small like this, we call it gravel. The clinical presentation can vary, so typically right upper quadrant pain could radiate to the right shoulder. Again, just having stones, there's usually no inflammation, but now if a stone blocks the bile duct or gets stuck in here in the cystic duct, or worse, down here where the pancreatic duct comes in, that can actually cause pancreatic juice to back up. And remember, that's the most common cause, one of the most common causes of acute and chronic pancreatitis is gallstones. Typically the pain, if there's going to be any, is going to be worse after meals, especially fatty meals. So you're going to feel a lot of pain. That's because you release cholecystokinin from the fat hitting the duodenal cells, and then that's going to tell the gallbladder to contract, and that's going to worsen the pain. Can also be associated with general dyspepsia, nausea, vomiting, or fat intolerance. Now, the basic cause of having gallstones is an imbalance between cholesterol and bile salts and phospholipids. So you can have an excess of cholesterol or deficiency in the bile salts. And this typically means up in the liver, when the bile was made, it wasn't fine-tuned enough. And so the liver wasn't able to actually take out, put in enough bile salts, synthesize enough of them, or there's too much cholesterol or fats that were trying to be removed. There's three types. The most common type of gallstone is a cholesterol stone, so it's made from cholesterol. Rarely you can get pigment stones. We already saw that. Bilirubin pigment stones, that can happen in the case of the indirect jaundice. And then mixed stones, where you have kind of both bilirubin and cholesterol mixed in. So cholesterol, 80% of stones, often mixed with the conjugated bilirubin, that would be the mixed stone. And the factors would be female gender obesity. So fair, 40, fertile female are the 4 F's of cholesterol gallstones. And diabetes with insulin resistance, type 2 diabetes, dramatically increases the risk as well. Pigment stones are about 20% of all gallstones, and that's going to be more associated with bilirubin disorders that we've already talked about. So the prognosis is usually good for gallstones, but patients could get recurrent biliary colic. They can actually develop acute cholecystitis with gallbladder inflammation infection. We'll talk about that next. They can develop choledocholithiasis, which is a stone in the biliary tree. Acute cholangitis, so bacteria infect the biliary tree, partly because of lack of proper drainage, because of a blocking gallstone. Gallbladder mucocele, the gallbladder fills up with mucus, not pus, but just mucus. Gallbladder ileus, that's where the motility actually pushes the gallbladder into the duct there a little bit, and basically stops all motility. So basically there's no peristaltic waves. Remember, there's smooth muscle all throughout the biliary ducts that should propel bile through it. Gallstone pancreatitis, which we already talked about, and then gallbladder cancer, adenocarcinoma, chronically can occur usually from the chronic inflammation. So the assessment for gallstones, again, ultrasounds are our best test. ERCP can visualize stones in the bile duct, and then the HIDA scan, the scintigraphy, would give you the clearest view of the biliary system. The treatment often is going to vary. Usually in asymptomatic treatment of patients, we just encourage good diet, maybe some herbal therapy with cholagogues. Now, it's very important whenever using any herb that can stimulate bile flow or contraction of the gallbladder system, that we make sure the stones are not too large. I mean, so anything, little stones will probably come out just fine with those kind of therapies. But we got to be really careful not to cause a stone to kind of go from the gallbladder, become stuck in the bile duct, which can cause acute cholecystitis or docholithiasis. So that's always a caveat I have with patients. Like, we got to be careful about using any of those with gallstones. That would apply also to things like drinking olive oil and the olive oil flush, as well as that. We got to make sure the stones are not too big. And that can be often confirmed by ultrasound. So if it just shows small gravel, that sort of thing, the likelihood of that's going to be less than maybe a large stone in the gallbladder, which would not be able to pass through. In fact, I've seen stones that are the entire size of the gallbladder, one stone. So one stone basically fills that whole cavity here. And that's not going to be good if you now encourage therapies to get the gallbladder muscles to contract and so forth. For symptomatic patients, the typical approach is cholecystectomy, removal of the gallbladder. So that's cholelithiasis. Again, most of these cases are asymptomatic and benign. Finally, I just want to mention something about cholecystitis. This is inflammation of the gallbladder. It's a common complication of cholelithiasis. It's typically acute, but it can be chronic, and it's a common cause of right upper abdominal pain. So acute cholecystitis, the gallbladder becomes filled with bile, and that static bile can lead to a strong acute inflammatory reaction. And about 90% of these cases are due to a stone in the neck of the gallbladder. So a stone gets stuck in that cystic duct there. Usually manifests with the right upper quadrant abdominal pain, can be severe, and we can see fever and nausea, vomiting, see elevated white cells, possible jaundice. All of these would be kind of urgent signs to get the patient to a place where they can get potential surgery. Mild attacks might resolve in a couple of days, whereas about 25% require immediate surgery. And the reason why is the complications. So one could be what's called an empyema, which is a inflamed gallbladder that's grossly distended with pus. Usually that's because of bacterial infection on top of all that inflammation. And that can actually rupture into the peritoneum, resulting in peritonitis. So gallbladder rupture is a complication there. And then cholangitis, and that results in complete blockage of the bile duct, and that leads to infection. We saw that, another name for that, called ascending cholangitis. And a classic kind of clinical finding there is what's called Charcot triad, and that's epigastric right upper quadrant pain with fever and jaundice. That indicates usually cholangitis. And then other complications would be the same as the cholelithiasis that we already saw. So the treatment here would be physical exam, positive Murphy sign, as well as the Charcot triad. Ultrasound, HIDA scan is going to be the most sensitive test there. But typically that would be either treated medically with antibiotics and pain relievers, or typically cholecystectomy, just the gallbladder would be removed. Now, you can have chronic cholecystitis, and that's usually associated with gallstones, the cholelithiasis. Leads to repeated gallbladder spasms and fibrosis over time, which results in a thickening of the gallbladder wall. And the gallbladder wall actually becomes filled with chronic inflammatory cells. And usually this has no superficial bacterial infection. This is more just a chronic inflammatory process. Most of these cases will require surgery to remove the gallbladder because of the potential complications of ascending cholangitis, gallbladder perforation, and then that could result in peritonitis and septicemia. So the typical approaches biomedically for these chronic gallbladder disorders, the cholecystitis, acute and chronic, would ultimately be cholecystectomy. All right, so that wraps it up for all the liver and gallbladder disorders that you should need to know and that are commonly or somewhat commonly encountered in primary care typical settings. And many acupuncture practices will often see patients with especially the viral hepatitis and whatnot, and so it's important to know a little bit about kind of the underlying pathophysiology. What are some of the assessment methods? What are we trying to track over time? What are the basic treatments and so forth?